So the report that we had at this ASCO this year was looking at the second-line cohort of patients who had had one previous therapy. The data for the dose escalation is not mature yet, so we didn't report on that. What we did find was there were 101 patients on study so far, 63 of which were valuable for their response at 24 weeks. And we found that 82.5% of those patients had met the first milestone, which was having a PCR less than 1%. There were 7 subjects who did wind up getting dose escalation, 3 of them at that 24-week period, and then 4 at a 48-week period when their PCR was greater than 0.1%. We chose not to present the data for those patients because it's very immature and there aren't quite enough of them to really say much about it, but hopefully in a future publication we will be able to present data about how those patients tolerated the dose escalation and most importantly whether it was effective. We do have data on higher levels of dosing. The patients with the T315I mutation, which is a rare but important mutation that confers resistance to most TKIs, the FDA-approved dose for that patient population is 200 milligrams BID, so that's the top dosing level that we used in this study. And in those subjects from our earlier data, we know that the dose is fairly tolerable without much increase in toxicity. So we expect that the patients on this study will tolerate the dose well. I think the big question is whether it's going to be an effective strategy for improving their response if they didn't hit those initial milestones. I think it shows that it is a very tolerable drug, and I think that's really in CML, 15 years ago when all we had was imatinib, patients were going to stay on that drug as long as they needed to, regardless of side effects. Now we've got 6 FDA-approved TKIs, so major reason for switching from one to the other is tolerability. So in addition to efficacy, the tolerability is a really important factor. I think previous data have also showed that asciminib is quite tolerable. One of my colleagues, Dr. Hockhouse, is doing a presentation on a larger study called Ask for Start, which I believe is on Tuesday at ASCO, looking at frontline asciminib versus nilotinib. And in that study, his data show that about roughly 2 times the number of patients discontinued nilotinib versus asciminib. And that also from the Ask for First study, which was asciminib versus investigator's choice in first line, we also found that particularly compared to the second generation TKIs, asciminib appeared to be tolerability. Those are data presented at last year's ASCO. So I think our study corroborates the previous studies and ongoing studies in parallel showing that it's a very tolerable drug for most patients. Not that there aren't side effects and the patients discontinue, but that it certainly is quite tolerable in the long run for them. To enroll in this study, one needed to either have failure to reach the designated endpoints for effectiveness or lack of tolerability as defined by the investigator. So as one might expect, the patients that change due to lack of tolerability had a somewhat higher major molecular response at 24 weeks compared to those who changed for a lack of effectiveness, just reflecting the nature of the disease. It was likely still very sensitive to TKI therapy. I think it shows that there's a major need for patients to have a tolerable drug. Again, even for patients that are going to consider treatment discontinuation, they need to be on therapy for at least 3 years. So that's a long period of time to be putting up with unpleasant side effects. So I think it remains, no matter what TKI someone starts with, a major reason for changing. And again, because asciminib seems to be fairly well tolerated, I think it's a good option for patients who are not tolerating their previous therapy. The major novelty behind this study is the dose escalation, and again, we don't have mature data on that, so we're really looking for the readout on how many patients required dose escalation and how many of them were then able to meet their response criteria, both in the first line and the second line cohort. This is a strategy that had previously been used for imatinib when it was the only TKI. Often patients that weren't hitting those milestones would have dose escalation, so it's reasonable to attempt that with later generation TKIs as well, especially one that's as well tolerated as asciminib. So we're really looking forward to seeing those data as they emerge. The second thing I think that's really the leading edge of the field is treatment discontinuation. So again, right now per the NCCN criteria, if one has been on therapy for over 3 years and has had a very deep molecular response, we can try stopping their therapy altogether, and roughly 40 or 50% of patients will be able to stay off TKI therapy long term. So I think that's really the goal. For many patients don't like to be on a medication their whole lives. They do have some side effects, even if they're low grade, that over years can become very bothersome. And obviously there's a pharmacoeconomic rationale as well. If you can treat people for a fixed duration and then stop their treatment, that's certainly preferable to keeping them on a treatment that might go for decades. So I think we're looking forward to both of those things. Those are both longer term outcomes that we'll have to wait a while to see how they play out. So one, as I just mentioned, is the treatment discontinuation. I do think that's an important goal for patients and also just for, as I mentioned, pharmacoeconomic reasons. The other is there do remain some patients that have poor outcomes, that are refractory, that have certain resistance mutations. And so I think there's always going to be a subset of patients that doesn't do well with whatever we've got, and we need to look for things that are better for them.